As Anna said, I am Zeela Zaizay. I'm the project officer of the integrated NTDS response program in Liberia. One of the things I'll be talking about is Ebola, our experience with Ebola and what we did during Ebola outbreak. So Ebola is a deadly viral disease that currently has no cure. It was first identified in the 1970s. It has occurred several times in the world, but the most deadly outbreak occurred in West Africa during the periods of 2014 and currently running. Case fatality rate, the death rate amongst people who suffered from Ebola stands at the average of 50. With early diagnosis and access to adequate care, a person, about 25% could die of Ebola. Without adequate access to care and early diagnosis, you can have up to 90% of people with Ebola dying. I will talk a little bit too about neglected tropical diseases. So it's important to help you understand what is meant by neglected tropical diseases. And they are a group of diseases that are found in tropical countries. They are diseases that are neglected. Basically, resources are not committed to them. Healthcare workers have little or no knowledge about these diseases. So, and these diseases occur in communities where people are stricken by poverty. So there are a group of them, including leprosy, Borrelia ulcer, a disease that leads to serious ulcerations, big ulcers. Onchocerciasis, another one is elephantiasis. It causes very big legs of people who suffer them, and several of them grouped together bear the name neglected tropical diseases. Before the Ebola outbreak began in Liberia, I'd like to give you a little introduction of what Liberia is. Liberia is Africa's oldest independent nation. Liberia is a founding member of the United Nations. It is a founding member of the African Union. It is located along the west coast of Africa. A very small country in terms of population because we are just 4.7 million people. And poverty-wise, 63.8% of the people live on less than $1 a day. Before Ebola began, all of us, you partners, members of Effect Hope, American Leprosy Mission, the Leprosy Mission Ireland, and all of us were supporting the healthcare delivery system in Liberia. And we were working towards strengthening the healthcare system to respond to neglected tropical diseases. We were providing essential medicines and services to the healthcare delivery system of Liberia. So we were on the ground and we had a working relationship with the health ministry and healthcare workers in the field prior to the outbreak of Ebola. In December of 2013, Ebola first occurred in Guinea, but due to the weakness of the healthcare delivery system in Guinea was unable to detect that they had Ebola. So it was misdiagnosed and thought to be a different disease called cholera. So it was not until March when Ebola crossed into Liberia, and also in Liberia, inexperienced healthcare delivery system in Liberia also was not able to pick up that they had this disease called Ebola. It was not until around the 22nd of March that Guinea confirmed that it had this Ebola outbreak in its country. And that caused Liberia to also investigate this strange experience it was having. By the 31st of March, Liberia was well convinced that it had Ebola also into its territories. But because of our involvement with the healthcare delivery system, by March 28, we became members of the Ebola Case Management Committee, the first committee established in Liberia to address Ebola. For us, all of us, we took Ebola quite seriously from the very beginning, probably because we were into health system strengthening, and because we also had been working in Uganda and had some prior experience of what Ebola was. So we became the very first donors to sustain the healthcare delivery system of Liberia with personal protective equipment. The personal protective equipment is a suit that is used by healthcare workers in Ebola response. It completely seals the healthcare worker in such a way that he can work in environments where there are high risk, but then he is fully protected against getting infected with these Ebola organisms. So we did a great work in sustaining the healthcare delivery system until Ebola was considered that serious globally, and then other countries and other people began to provide support to the system. By June 2014, the entire healthcare system in Liberia had shut down, and focus and emphasis were placed only on Ebola. Then, interestingly, in July, even the healthcare delivery system, healthcare workers were basically avoiding even addressing Ebola because at the rate at which healthcare workers were dying. So the intensity of Ebola was such that we had about 10,572 deaths occurring globally, with about 41.4% of people affected by Ebola dying. Amongst them in Liberia were healthcare workers. So we had up to 499 healthcare workers dying in Liberia. And you will observe that the ratio of healthcare worker to patient in Liberia is 1 to 580. But this is even quite more not impressive because even these, the healthcare workers in Liberia are poorly trained and inexperienced. So that makes even a greater gap than what we kind of like see here. So it is important to understand what led to Ebola being a real global issue, a real global concern. And from my personal perspective, Ebola was not the problem. The problem was Ebola rather revealed the seriousness of the problems we had occurring in West Africa. So Ebola was not the problem, and there are true problems. The real problems need to be identified, taken seriously, and addressed. And the problems were that, firstly, we had shortages of healthcare workers within the West African region. And even the few healthcare workers we had were poorly trained and not very qualified. Secondly, they had limited logistics to work with. In as much as we went to school, learned about protective equipment, believe me, my first time ever touching one was during the Ebola outbreak. So we had poor occupational safety and patient care also. And then one other issue was that lots of healthcare responses in Liberia were based upon, were dependent on donor funding. And donor funding were basically disease specifically directed. They were directed to malaria, HIV and AIDS, and tuberculosis, leaving the rest of the healthcare delivery system relatively neglected. Neglected including disease surveillance and response, neglected including community ownership, including community awareness and everything. And so these kinds of problems allowed a disease called Ebola to walk through and cause serious devastations in a shorter period of time than they would have done if the healthcare delivery system had been strengthened prior to the outbreak of Ebola. So with the, in the photo to the left, you see at the early beginnings, this is what our Ebola treatment units were like. So you see how this guy is kind of touched. This is an Ebola client seated in there. And you see how with the provision of protective equipment, And as healthcare workers were learning and fighting, they began to gain confidence with the protective equipment we provided. They were more confident and began to turn the tide. So I want to talk quickly, let you know the impact that we all made during the Ebola response, and through the next few slides. And I'll begin with the critical supply that we shipped to not only Liberia, Guinea, and Sierra Leone helped a lot. It protected healthcare workers. It gave the healthcare delivery system access to essential medicines that they needed to respond to Ebola. Ebola doesn't have a cure, so what was much more important was to provide, address problems that the individual patient had. It was important to make sure that all clients had access to adequate vitamins, adequate nutrients, and so forth. So they meant having a wide range of different kinds of medications available to them. And we are blessed that we were able to provide the kinds of critically needed resources during the Ebola response. So here in this photo, you can see I'm the one here standing, and this was during one of the major donations of protective equipment to the Ministry of Health. The fellow here is Minister Linka receiving the donation, and you see several press people standing around and capturing what we were doing, because this was a milestone in the fight against Ebola to receive such large donations for the first time in country. So in this photo, you see an example of a health facility in Liberia. So we reached 172 rural health facilities with essential medicines and supplies, including this facility that you see in this photo. During Ebola response, one of the things that we did that was quite effective and efficient, a model that we definitely should adopt and support, is the involvement of community people in their own responses, allowing people at the level of their household to take ownership of their own health, allowing them to be trained to be very responsive so that they can early pick up signs of illnesses, and they can be responsible to report them to the healthcare delivery system so that they know how to provide basic first aid and responses, even to a disease that they know nothing about. So one of the impacts we made was that we were able to reach 1,600 households with hygiene kits. These hygiene kits were made of hand sanitizers. They had gloves in them. They had soap. They had body lotions, because it was important to keep the skin well hydrated and well nourished, because we're using lots of chlorine during the Ebola response. They had chlorine in them as well. Those kits had educational resources that people in the household could use to learn about Ebola. So there were a couple of things that a household needed to respond to Ebola. Together, we called them the household kit. And we provided that to communities. And that was very helpful in helping up to 11,350 people to protect themselves against Ebola. We provided infrared thermometers, and the infrared thermometers we provided up to 391. So in the communities where we were supporting, the communities formed their own task forces. We allowed them to lead their own fight. And so they will use the non-touch thermometer and monitor the temperature of every community member every day. So if they came to your house and knew that your house had 5 people in there, they wanted to see all 5. If they saw only 4, then there is an alarm that someone could be hidden somewhere in the house and may not be well. So if the temperature show above normal, then the community will document that and make sure they link you to the healthcare delivery system. And that was quite helpful because it allowed them to pick up people who had signs of Ebola quite early, and it helped them to prevent spread within the household. And definitely, if you prevent spread within the household, you definitely have prevented spread in the community and in the nation at large. So one of the things we did was that we trained 1,029 community volunteers, and these were people who volunteered to be trained, volunteered willfully, because we all knew that we were in harm's way. We were learning something that was quite strange. We were learning something that was killing us, but yet and still we were willing to learn and fight at the same time. So people who you see in the photo on in the left there are all volunteers, all adults willing to sign off to take their own risk to protect themselves and their communities. And the lady you see here is an Ebola survivor. One of the things we did was to get people who were victims to become victors. So we recruited Ebola survivors, and in her hand here is her certificate given to her when she returned from the Ebola treatment unit. So she and several of them will go along with us, and they will use their stories and their testimonies to help dispel the misconceptions that people had in the communities and help healthcare workers to believe that volunteers to believe that they could actively get involved. So when these volunteers were trained, they were responsible to reach people in their own communities, and that helped a lot. I'm sure you heard that in some communities, people fought healthcare workers. In some areas, they killed them. But when the volunteer was working in the community where she was known, it was easy for people to listen to them. And it was easy for people to express their misconceptions, their doubts, their barriers to taking actions. And it was easy for someone in whom they had confidence to help them address these barriers. And so this was a very effective strategy that helped us to beat Ebola. Henceforth, we should put much more attention toward getting people in their communities, in their households, to take ownership of their own health. And they should lead it in such a way we can continue to make great impacts within countries where people are poor and probably do not have access to good quality care, as we may say. So one of the things we did was that we provided up to 33,000 plus protective equipment. And so with the equipment you see here, I took this picture in one of the Ebola treatment units. You see healthcare workers using some of the protective equipment we have supplied to them. And we see healthcare workers in the field going out to collect bodies for burial using protective equipment that we had also supplied to them. And these protective equipment protected healthcare workers and were greatly responsible for the decline in the health of healthcare workers by December 2014. Critical during the Ebola response were access to physiologic needs. Assessments we conducted showed that people were not only worried about the deaths of their relatives, but they were worried about access to safe water, food, and so forth. So one of the things we did was that we were able to help people to have access to safe drinking water in communities where they lived. And as people had access to safe drinking water, it protected them from coming down with other diseases that would have probably led to their deaths if they had gotten sick during the time when access to healthcare or healthcare facilities was quite limited. So in this photo, you see people accessing water from a tap stand that we had provided to their community here. We provided water supplies to several Ebola treatment units. And in this photo, you will see me, I am on the top of an Ebola treatment unit, and I am servicing the, what we call the high lift water pumps, because these pumps were not built to pump highly chlorinated water. But because of Ebola, all water supplies our Ebola treatment units we had to be sure that they were well chlorinated. And so these pumps will get broken very frequently, and so we had to keep checking them, monitoring them, and then servicing them so that the Ebola treatment units were constantly running. We were able to assist 178 schools to reopen following the reduction in cases of Ebola. Reopening the schools meant that the schools had to meet several protocols, several conditions for reopening. And so some of those things meant that the school had to have access to water supply, they had to have access to sanitation kits, they had to have access to protocol on Ebola, faculty had to be trained, there had to be committees that were responsible to report illnesses and link these sick people with the healthcare delivery system. They had to be withholding units at their schools and so forth. But we blessed that we were able to all be a blessing to up to 178 schools to reopen. And in those schools that did reopen up to date, there has been no reported cases of Ebola amongst the students and the population. So we can be grateful to God to say that we protected. We all have been able to protect 588 students and faculty from Ebola within their school environment. During the Ebola response, we extended our coverage to special groups or vulnerable groups, and they included people who were deaf, people who were dumb, and people who were blind. In this photo, you see this is a home of people who are blind, were able to renovate their building that was leaking, were able to renovate their access to water, a well for them, give them access to water supply. And here you can see them being thankful to God, here praising and singing after we were dedicating their project to them. And so we were able to extend our support to not just on people in their communities as such, but we're able to identify people with special needs, and we are blessed that we're able to reach these kinds of people who have more touching needs than people who were physically, or people who were whole, in other words. In this photo, you see community volunteers, some of the volunteers we had trained, working with people in their communities, conducting education and following up on them, reinforcing education, asking them about challenges they have and helping them to address their own barriers to taking action. In this photo, you see this is a bucket. There's a bucket. These are, one of them is a cream, the other is a hand wash. And we see people using the resources we were providing to them. And of course, this photo is not too clear, but if you observe the faces of these two kids, you see their faces are not relaxed. So in as much as they had some access to resources, but then still you see the fear of Ebola still in the faces of the kids in this photo. Our essential medicines were able to reach the healthcare delivery system, as we said. And in this photo, should you see map on them is because you at Fight Hope, I work with partners, and the partner in Liberia responsible for this distribution is MAP International, and so that's why you will keep seeing the map photos as we move forward. So here I am at an Ebola treatment unit, providing supplies, and that was something we did constantly, making sure that the Ebola treatment units had adequate logistics to provide patient care. And this treatment unit is called the Arlington Lake Ebola Treatment Unit. This is the ELWA Ebola Treatment Unit. Two of the treatment units that manage lots of cases during the Ebola response. In this photo, we provided a grant to some blind people because a major concern they had was the issue of economic capacity. So with the grant onto them, they were able to produce soap that they would put out in the market, and that would help them to generate some resources. So on this day, they had invited us to go and see what we had done for them. The fellow in the blue t-shirt is a pastor from the local church in the community that we worked with to provide care to these people. Amongst the special group of people we worked with were Ebola survivors. And these Ebola survivors were people who had unique needs. In this photo, you see Ebola survivors being fed, and I'm the one in the blue here. In this photo, I'm the one in the blue there. We provided psychosocial, religious support to Ebola survivors, but we also provided them physical resources they needed, including food, clothing, and so forth. Amongst the resources we gave to Ebola survivors were audio Bibles, because one of the things the survivors needed the most, and they do need, is psychosocial and religious support. Up to date, many Ebola survivors are not yet reintegrated with their own families and societies, because it is evident that the mode of transmission, it is evident that we do not fully understand Ebola. It is evident that a person can carry the Ebola virus in the eye for up to 6 months. Yes, Emory University confirmed, proved that. And so with those kinds of facts, people who watched relatives die of Ebola, people who watched a disease walk between them, will take them quite a long period of time to not stigmatize or discriminate against people who survived Ebola. So with psychosocial support, religious support, probably we can be able to save Ebola survivors from developing real serious mental illnesses in the next few years. It didn't all happen quite easily. One of the things we had to do was we had to protect ourselves while we were working in the field. And there are some methods that you probably may not have heard of. So I thought it would be lots of fun to let you see that many times we chose to sleep in the vehicles, because at least we were sure that we knew who sat in them, we knew who lied down in them. You didn't want to try sleeping in a hotel or somewhere else because you didn't know who walked there, you didn't know who slept there. So a vehicle can be a comfortable place to sleep, actually. Reaching people in rural environments can be quite challenging. So I thought to have you see a photo of a rough terrain vehicle. This is a Land Cruiser hardtop, one of the best vehicles for working in rough terrains. But even the vehicles themselves can tend to realize that terrains can be rough. But we're blessed that we're able to brave these storms and go beyond them, because we took ownership of our own health, and we realized that if anybody could impact the environment, we ourselves could do it better. And so we're grateful that we had the kind of support from you all to be able to reach the hard-to-reach environments. I thought to let you see this photo. At the beginning of the Ebola outbreak, when I was trying to convince Anna that we can get involved and we can help. There were lots of confusion in Liberia, misconception, and so much. And I told her that we can help. And she said, yes, but how do we help in a way that we do not put people at risk? It was a difficult question answering. But then she asked me, Zeela, so if we are going to help, is it possible that you would not take any risk? I said, yes, you can rest assured I would not take any risk. And so I surely did not take any risk until we had contained the virus. Then I told her, Anna, I took lots of risk. But believe me, if I had contracted Ebola during the Ebola crisis and died for me, that would have been a noble death. It wouldn't have been a problem for me. In this photo, I'm the one walking on the roof of an Ebola treatment unit. And if you see in the little yellow cycle, there is a little wooden wall made of plywood. And that is because somewhere in the front of this building, is a concrete structure, which was a clinic called the Island Clinic. It was a clinic providing care to people in the island community. But with Ebola and the high influx of people infected by Ebola, this unit was quickly constructed to hold more patients. In no time, the number of patients reporting per day outnumbered the number of beds available, so another unit was constructed here. But still, the number of clients were so high that we had to have this plastic sheet put between these two buildings so that they would accommodate more people. But then the water source for the Ebola treatment unit was a well that had now been surrounded by clients. So the way to keep the well safe was to build a wooden wall around the well. And the way to reach the well meant then we had to climb along the side of the building, carefully walk over the building, and go down into this little cave and work. And of course, you see, we had to nail these pieces of planks here so that you don't fall. Because if you fell, you can be sure you were falling straight on an Ebola client. So the current situation of Ebola clients in Liberia is that they are highly stigmatized. And it will take a real long time for the people in the West African region to actually stop stigmatizing people with Ebola. We've done a lot for many years to have people to stop stigmatizing leprosy, right? And that has been an easy thing. Then what more Ebola that they watch before their very eyes, walk through them and kill their loved ones. Another thing is that with the decrease in the number of cases in the West African region, there is decrease in support toward Ebola survivors. I chose to share the photo of this Ebola survivor. She is a female. She was pregnant during the Ebola outreach. She didn't receive any medication at the Ebola treatment unit because she carried a child in her abdomen, so she was just left to be left by herself. But the grace of God is unexplainable. She survived Ebola in the Ebola treatment unit without taking any medication. But then she returned to her house where she had lost her father, lost her mother, lost all the older siblings. Out of from a family of 13, there are only 6 survivors. And she is the oldest person who has to attend to the family. But then she had Ebola. She returned to her community still carrying the child in utero. But because of the stigma she experienced in her community, 3 days after she returned home, she had this severe abdominal pain. She wasn't eating. Nobody wanted to see her. Nobody was talking to her at all. So when she went into this pain, she tried to make her way back to the Ebola treatment unit because for her, life was better in the treatment unit than in her community. Unfortunately, along the motor road, no one was willing to pick her up. So she dispelled the fetus right on the motor road, became extremely weak. Still, no one was willing to touch her. So she had to make her way back to her house with the dead fetus. And you can imagine the kind of trauma that is for this young lady. Currently, where she is, people are still avoiding her. But she has to be able to feed her family in an environment where she is being avoided. And she is just an example of several one of them. Another one of them, who is the Secretary General of the Ebola Survivors Network, she's called T. T was a second-year medical student. After T survived Ebola, T literally had to learn the alphabet again. Today, T is learning how to read fairy tales. And so when I talked to her, I said, T, do you think you'll ever do medicine? She says, Zeela, I still want to become a medical doctor. And now I have even a greater passion to do medicine. And I said, but with your memory, with your mental status, do you think it's ever possible? She said, I don't know when that will be, but I hope and pray that one day I can still become the medical doctor that I want to become. And with that said, there are lots of Ebola survivors. There are lots of orphans who do have special needs. And so it's quite important, in as much as we kind of like contain the Ebola disease, to pay attention to these unique people who still have serious needs that they will face for a long period of time. Many of them have existing illnesses, including numbness, including memory loss, like I talked about. Some of them are having visual impairments. They can see quite well. Some of them are having problems with hearing. But the problems vary from one person to another. So I spoke of the psychosocial needs that they do have. One other need they do have is economic need. Like I told you the story of Josephine. She has to fetch for her household. So they have lots of economic challenges, and therefore they have economic need. A case of one of the survivors is called Wida, and through our support, we provided Wida a little grant to establish her own little market. So this is the market of Wida. This is one of my colleagues called Thomas. He had gone on a supervision visit to see how Wida and her business were doing. But Wida was able to do her market. Wida has been able to return to school. And interestingly, Wida got married this year. So not all of them are suffering the kind of stigma they are. In areas where people are working with the survivors, working with their families, working with the communities, the survivors can become integrated. And that's what I chose to present this photo, that it's possible that these people can get integrated. It's possible they can regain their economic viability if we provide the kind of support that they do need. If we do focus on them, it's quite possible. So due to the Ebola, there are several things that we have learned and several things have been possible. Ebola has impacted the West African environment, at least Liberia, in several ways. One thing it has done is that it has helped healthcare workers to be trained to Ebola, although they got trained the hard way, but at least they are trained to Ebola. And now there is intensified monitoring of ill people within Liberia. Because of intensified monitoring, an ill person is easily picked up. An ill person can easily be reported to the healthcare delivery system. So in that case, the chances that Ebola will spread as it did in the past is now slim. But it is because we have been able to help people in the community to take ownership of their own health, we can now boastfully say that illnesses are being closely monitored and reported than it was before Ebola. Besides just healthcare workers, people in the general community are trained. People in their households are trained to note signs of Ebola, or at least to note signs of illnesses and to report them early. So like Ebola taught us, a person doesn't need to know the definition of the disease. What he or she needs to know is signs and symptoms of diseases, and he or she needs to know how he or she can attend to a sick person who has a disease knows nothing about, and how to report the person very early to the healthcare delivery system. If we can help people in their communities, in those regions, to take those kinds of ongoing actions, we can help them to prevent not only Ebola, but many other diseases, including emerging infectious diseases we probably haven't yet gotten to know about. So one of the things, because of this, there is reduced burden of diseases, especially waterborne diseases. We're experiencing some reductions in diseases such as diarrhea, because many people in Liberia now have their hand sanitizers. They take them along with them, and we usually tag them to our belt straps. So the kids going to school will take their hand sanitizers along. They are now practicing hand washing. And over time, should they continue on practicing, it will become a health habit. And subconsciously, they will continue to reduce the burden of illnesses within their populations. one of the areas we want to focus then with our experiences from Ebola is to look beyond just single diseases. Like we saw, one of the problems responsible for the spread of diseases was that resources were basically committed to war fighting HIV and AIDS, fighting malaria and tuberculosis. So with lessons learned from Ebola, the Ministry of Health Liberia and us partners have designed a new approach towards case management. And we have drafted a plan that will help us to look beyond beyond just single disease response toward largely helping a healthcare delivery system to become strengthened as opposed to being ignored. Before Ebola, neglected tropical diseases were largely ignored by the healthcare delivery system, and many programs were focused on single diseases. For example, a person or an institution will say, I'm interested in, let's say, worms. So I'm going to train healthcare workers in worms, train them how to manage worms, and then leave every other thing out of the picture. And in some communities, people were very far from healthcare facilities because healthcare facilities were not accessible to people. They were program specific. So you could go in a community and there is access to HIV care, but there is no access to other cares because program specifics are providing as HIV care only and not care to the general population. So with lessons learned from Ebola, we are developing new innovations, new strategies, and so forth. And because of that, the Ministry of Health in Liberia now has a national strategy developed, at least in the final draft stage, to address neglected tropical diseases. That means diseases including leprosy, Borrelia ulcer, elephantiasis that causes a very big leg, and several other of them. There is commitment being developed among partners toward providing full access and treatment to the management of NTDs throughout the healthcare delivery system. And when I say this, what I mean is that throughout the healthcare delivery system, meaning that we want to make sure that people in their community understand neglected tropical diseases and are able to observe and monitor themselves. They are able to provide care for themselves. They're able to support family members who are ill, and they are able to report to healthcare delivery system. We want to make sure that people have access to care in the communities where they live. We want to make sure that healthcare workers are adequately trained to early diagnose, to manage, and report cases. We want to make sure that surveillance systems are strong at the level of the community. And of course, we want to make sure that even national level, there are political commitments and political wills to address neglected tropical diseases. We want to make sure that there are adequate resources in such a way that the entire health system can be strengthened to be responsive in a very effective and efficient way. So this is quite complex, but in it, we want to do a lot with planning, a lot with training, a lot with contact tracing, a lot with referral system, and a couple of stuffs that when put together strengthens the entire healthcare delivery system. If we are able to provide adequate support towards strengthening the healthcare delivery system as opposed to focusing on a particular diseases, there are lots of impacts we will make. A few of them is that with the little resources that we have, we will make a greater impact, because resources that will train somebody to be responsive to only tuberculosis can now make that person be responsive to leprosy and to other diseases as well. We will decrease the burden of poverty and morbidity within the population, like leprosy and Borrelia ulcer. If the healthcare delivery system is identifying cases and patients soon enough, is treating them soon enough, it means that people who will go with disability will be quite reduced. It means people who will have stigma and discrimination in the population will also be significantly reduced. So that in that way, we can proportionally be able to reduce the burden of poverty within the population. Through the integrated NTDS approach, we can be able to increase access and treatment within the communities, because instead of having people having access to only Borrelia ulcer treatment or only leprosy treatment, healthcare facilities will be quite equipped with resources and train people to provide care to all NTDs, all neglected diseases requiring case management. And of course, we will definitely reduce stigma and discrimination if we are able to provide that kind of holistic care. And at this point, I must add that when a healthcare worker is kind of like being trained to respond to a single disease, the rate of acceptance is lower. But if he or she is being trained to respond to a group of diseases, many diseases, the perceived seriousness is better than if you were telling someone only about a single disease. So with integration, we can be able to identify cases much earlier, and people can have increasing access to care, like I said. So to wrap up or to close up, I'd like to speak of what the next steps are. We are recommending as the next steps. Many of them I've already said, and they include the integrated management of the neglected tropical diseases. So that focus is not disease specific, but resources are able to provide care and knowledge, training resources over a group of diseases as opposed to one. Second is to strengthen the surveillance and reporting system within the healthcare delivery system of our country. And that includes helping people at the level of the community to be trained and to take ownership of their health like they did during the Ebola crisis. One of the things we also want to prioritize is getting kids in their schools to continue to use these hand sanitizers, but also to continue to teach them the importance of sanitation and hygiene promotion. If the kids continue to learn these things in school and practice them over several years, they will become a part and practice of the Liberian environment. And with that, we can be sure that in a very sustained way, we can reduce the burden of illnesses. So even if Ebola came in the future, it will not walk through the population because the people will be very responsive to not just only Ebola, but to any disease that might just want to walk through them. And then one of the things we want to see do is that during the Ebola crisis, we saw lots of collaboration amongst people. Collaboration between people who resided at the level of community, collaboration between political stakeholders, collaboration between donors, and so forth. So we want to put lots of emphasis on improved collaboration and partnership amongst donors in such a way that people understand the importance of health system strengthening, and they're able to partner together, collaborate together in such a way that the entire health system can be strengthened as opposed to what we were prioritizing during the post-Ebola phase. For the Ebola survivors, we want to continue to provide the kind of psychosocial and religious support that Ebola survivors do need. We want to see Ebola survivors having special learning programs, because an Ebola survivor like T, who is learning how to read fairy tales, can be helped out in a unique way but it has to be so much unique that the education system that's provided to her has to be tailored to her individual need. T cannot learn in a regular schooling system. I can't see how possible that is going to be, to have someone who was a second-year medical student sitting among third-grade students again. Something has to be more structured to address her need. And of course, we need to help survivors to become reintegrated into their societies. It is possible. T currently lives in a different community because people in her community would not accept her. And she doesn't only live alone, she lives along with 6 other kids also. And they are kids who are relatives, kids of her relatives who died of Ebola. And in Liberia, there are some kids who parents died of Ebola, and people are kind of like afraid of them and avoiding them because people do not fully understand this Ebola thing. And 2, there were lots of misconceptions about this Ebola thing, lots of cultural beliefs and practices. And as much as we kind of like help to wipe out lots of them, but people will still continue to stigmatize and discriminate against survivors unless we are able to work with them in such a way that they can become integrated into their societies again. So to close up, I want to thank you for not just your support, but your partnership that allowed us to defeat Ebola. Your partnership that has helped us to help strengthen the healthcare delivery system of Liberia to an extent. Together, if we continue to partner and provide the kind of resources in such a way that in an integrated and collaborative manner, we can impact the health of people living in a hurting world. Thank you.